Cervical radiculopathy and cervical myelopathy are two distinct, yet often interrelated conditions that affect the cervical spine, leading to significant discomfort, neurological deficits, and, in some cases, long-term disability if left untreated. To understand these conditions thoroughly, it's essential to delve into the anatomical structures involved, the pathophysiology behind the symptoms, the clinical manifestations, diagnostic approaches, and the various treatment options available. The cervical spine is composed of 7 vertebrae, labeled cone through 7, which support the head and protect the spinal cord, while allowing a wide range of motion. Between these vertebrae are intervertebral discs that act as cushions, absorbing shock and facilitating movement. The spinal cord runs through the vertebral canal, giving off nerve roots at each level that innervate different parts of the body. Any compromise in these structures can lead to conditions such as cervical radiculopathy or myelopathy. Cervical radiculopathy occurs when a nerve root in the cervical spine becomes compressed or irritated. This compression is commonly due to degenerative changes, herniated discs or bone spurs, often associated with aggregated degeneration. When a nerve root is compressed, it leads to pain, numbness, tingling, and weakness radiating along the path of the affected nerve. Patients often describe a sharp, burning pain, radiating down one arm, sometimes extending into the hand and fingers. The specific distribution of symptoms depends on the affected nerve root. For example, compression of this 5 nerve root typically causes shoulder pain and deltoid weakness, while 6 involvement often leads to bicep weakness and sensory changes in the thumb and index finger. The pathophysiology of cervical radiculopathy revolves around mechanical compression and the resulting inflammatory response. When a herniated disc protrudes into the intervertebral foramen or osteophytes form around the facet joints, the nerve root experiences both mechanical stress and chemical irritation. This dual insult triggers an inflammatory cascade, leading to nerve edema, ischemia, and ultimately dysfunction. The longer the compression persists, the greater the risk of irreversible nerve damage. Cervical myelopathy, on the other hand, is a more serious condition resulting from compression of the spinal cord itself, rather than an individual nerve root. This condition typically arises from cervical spondylotic changes, such as disc bulging, osteophyte formation, and ligamentum flavum hypertrophy, all of which narrow the spinal canal and exert pressure on the spinal cord. Myelopathy is characterized by a constellation of symptoms, including gait disturbance, hand clumsiness, urinary urgency, and sensory deficits. Unlike radiculopathy, which usually presents unilaterally, myelopathy often affects both sides of the body and progresses insidiously. The underlying pathophysiology of cervical myelopathy involves both mechanical and ischemic factors. As the spinal cord becomes compressed, there is a reduction in blood flow, leading to chronic hypoxia and neuronal damage. The pressure also disrupts the normal flow of cerebrospinal fluid, further exacerbating the ischemic environment. Over time, the spinal cord undergoes gliosis and demyelination, resulting in progressive neurological decline. Once significant myelomalacia sets in, the damage often becomes irreversible, emphasizing the importance of early diagnosis and intervention. Clinically, distinguishing between cervical radiculopathy and myelopathy is crucial for appropriate management. Radiculopathy typically presents with radicular pain, sensory disturbances, and weakness localized to specific dermatomes and myotomes. In contrast, myelopathy presents with more diffuse neurological deficits, including spasticity, hyperphagia, and positive upper motor neuron signs such as the Babinski and Hoffman signs. Patients with myelopathy often report difficulty with fine motor tasks, such as buttoning shirts or writing, and may experience frequent falls due to impaired balance. The diagnostic approach begins with a thorough clinical history and physical examination. Special tests, such as Sperling's test, can help identify cervical radiculopathy by reproducing the patient's symptoms with neck extension and lateral bending. For myelopathy, the Hermit sign, characterized by an electric shock-like sensation radiating down the spine with neck flexion, is often a key finding. Imaging studies play a pivotal role in confirming the diagnosis and assessing the extent of pathology. Plain radiographs can reveal degenerative changes, while magnetic resonance imaging (MRI) provides detailed visualization of soft tissues, including the spinal cord, nerve roots, and intervertebral discs. Computed tomography (CT) with myelography may be employed if MRI is contraindicated, offering high-resolution images of bony structures and the spinal canal. Electromyography (EMG) and nerve conduction studies can further support the diagnosis by identifying nerve root dysfunction. Treatment strategies for cervical radiculopathy and myelopathy depend on the severity of symptoms and the underlying cause. For mild cases of radiculopathy, conservative management is often effective. This includes rest, nonsteroidal, anti-inflammatory drugs and NSAIDs, physical therapy, and cervical traction. Physical therapy focuses on strengthening the cervical musculature, improving posture, and enhancing flexibility to relieve nerve root compression. Epidural steroid injections may provide temporary relief by reducing inflammation around the affected nerve root. However, when conservative treatment fails or when significant neurological deficits are present, surgical intervention may be necessary. The most common surgical procedures for cervical radiculopathy include anterior cervical discectomy and fusion, a CDF, and cervical disc replacement. A CDF involves removing the herniated disc and stabilizing the segment with a bone graft and plate, while cervical disc replacement preserves motion by implanting an artificial disc. For cervical myelopathy, surgical decompression is often the definitive treatment. The choice of surgical approach depends on the extent and location of spinal cord compression. Anterior approaches, such as a CDF or anterior cervical corpectomy and fusion, a CCF, are preferred for ventral compression, while posterior approaches, including laminectomy with or without fusion, and laminoplasty, are suitable for multilevel disease. The goal of surgery is to halt disease progression, as significant recovery of neurological function is less likely once advanced myelopathy has developed. Postoperative rehabilitation plays a crucial role in optimizing outcomes. Physical therapy focuses on restoring strength, balance, and coordination while addressing residual pain and stiffness. Patients are encouraged to maintain an active lifestyle and practice good posture to prevent recurrence. Regular follow-up with imaging and clinical assessment ensures that the condition remains stable and that any signs of recurrent compression are promptly addressed. In conclusion, cervical radiculopathy and myelopathy are complex conditions that require a comprehensive understanding of spinal anatomy, pathophysiology, and clinical presentation. Early diagnosis and appropriate management are essential to prevent long-term disability and improve quality of life, while conservative treatment suffices for mild radiculopathy.
Surgical intervention is often necessary for severe radiculopathy and myelopathy to relieve compression
and preserve neurological function. Educating patients about the importance of early intervention, lifestyle modifications, and adherence to treatment plans can significantly enhance outcomes
and ensure long-term spinal health.
Furthermore, ongoing research continues to refine our understanding of these conditions. With advancements in imaging, minimally invasive surgical techniques, and regenerative medicine, offering new hope for patients. As our knowledge expands, so too does the potential for more personalized, effective treatment strategies that can further improve patient outcomes and quality of life. Additionally, understanding the importance of patient education cannot be overstated. Clear communication about the condition, expected outcomes, and treatment options empowers patients to make informed decisions about their care. Collaborative decision-making between healthcare providers and patients ensures that treatment plans align with patient preferences and lifestyle goals. This patient-centered approach ultimately leads to better adherence, satisfaction, and overall health outcomes. Moreover, preventive strategies play a crucial role in mitigating the risk of developing cervical radiculopathy and myelopathy.
Promoting good posture, ergonomic workspaces, regular exercise, and weight management
Can significantly reduce stress on the cervical spine. Education about recognizing early symptoms and seeking prompt medical attention can also prevent the progression of these conditions and avoid complications. Finally, healthcare providers must remain vigilant in their assessment, monitoring patients for signs of progression and adjusting treatment plans accordingly. Continued advancements in medical technology, such as artificial disc replacements, neurostimulation techniques, and gene therapy, hold promise for improving patient outcomes and quality of life with comprehensive, patient-centered care and ongoing research. The future of managing cervical radiculopathy and myelopathy looks increasingly promising, offering hope for better management and improved patient well-being.